I multitask here. So our topic for today is nicotine. Is it good or bad for people with schizophrenia? Our objectives, we're briefly going to describe the actions of nicotine on specific neurotransmitters. We're going to list potential reasons for the high use that we see specifically of cigarettes, but potentially also of e-cigarettes and vaping in patients with schizophrenia. And then identifying some of the evidence related to the effects of nicotine on these patients. So as I was trying to think how to start this, I thought it'd be helpful to start at the very beginning. So one of nicotine's main actions is on our acetylcholine, nicotinic acetylcholine receptor. And just as a quick reminder, this is an ionotropic receptor. So it's made up of 5 subunits, either alpha or beta subunits, and we can have a number of different combinations of those alpha or beta subunits. 2 of the ones that we happen to see that we're going to, the alpha 4 beta 2, so varenicline, it works as a partial agonist on this. And we'll look at alpha 7 because this really has been the focus of some new treatment, focused on patients with schizophrenia, and we'll talk about how that's turned out. For this receptor, so both nicotine and acetylcholine can work on it, and it's a cation channel, so mainly sodium. Sometimes it allows calcium in on the muscles and the neurons, but by allowing the sodium or calcium in, it causes depolarization, and we can see an increase in the release of a number of different neurotransmitters, acetylcholine, dopamine, GABA or glutamate, norepinephrine, serotonin, and some of our opioid peptides. So this is important for a couple reasons. One, we're going to talk about for patients with schizophrenia, we see quite a bit of this, and they do tend to have a higher rate of nicotine dependence. So those nicotinic acetylcholine receptors that release dopamine in the mesolimbic pathway cause a release of dopamine, and they get that positive reinforcement, which may really lend itself to the development of dependence. Also, something to think about as a teaser for a little bit later on is the mesocortical pathway. So by activating nicotinic receptors in the mesocortical dopaminergic pathway, you can get a release of dopamine and potentially impact some of the negative symptoms. And we'll see if that actually pans out. So why are we focused on this? Well, one of the big reasons was due to prevalence. So originally there was a lot of concern because there were so many individuals with severe and persistent mental illness that were smoking. So we see elevated smoking rates, and I recognize these ranges depending on where you get your information, but I pulled these because they were, I think they tended to provide a really good picture of how patients with severe mental illness how likely they are to smoke. They gave us a really good range. So in one of the trials they looked at, it was double the incidence of smoking, of being a current smoker in patients that had a mental illness or a psychiatric diagnosis compared to patients who didn't have that. And I want to pause for just a second there. That prevalence actually is, it remains in place even if we're not talking about cigarette smoking. So these prevalence rates are for cigarette smoking. I was able to find one trial, so it's the results from the 2016 National Health Interview. So this was in over 33,000 patients, and they found that it again was almost that double incidence or double prevalence of patients with a psychiatric diagnosis that are using e-cigarettes compared to those that are not. And that was 39% to about 15%, so even maybe a little bit more than that. And current users of e-cigarettes were about 12% of the respondents that had a psychiatric diagnosis, and it was just about 3%, so almost 4 times more likely to currently be chronically using e-cigarettes. So even though this data is specific for cigarette smoking, when we talk about vaping and the electronic cigarettes, it looks to still hold. We see quite a bit of smoking quite a range in the smoking rates, with the ranges anywhere around 50% to up to about 90%. But one point that I did want to make is we do see high prevalence rates even in patients who have first episode psychosis. So this was a trial done in first episode patients before they had received treatment with antipsychotic medications. So when we talk about reasons for individuals for smoking, maybe it's not just from trying to deal with some of the side effects of the antipsychotic medications. There may be other reasons as well, as we see with that really high incidence rate of 92% for those first episode folks. So it definitely happens. Why? Why might we see those higher rates? That's a great question. We don't know exactly. We're going to look more in detail for the first two that are listed here, the genetics as well as the self-medication. But there may be social or environmental factors as well. If they're around a large number of people who also are smoking, they may have patients with schizophrenia or severe mental illness may be in a stressful environment. There may be socioeconomic stressors. In addition to that, that may increase the risk of picking up smoking. We're going to focus on the other two just for today. So looking at the genetic contribution, so originally it was, we see a lot of individuals who are smoking, but now that they're starting to look at, can they predict genetically who would be likely to develop nicotine dependence, develop other conditions, including schizophrenia, they've realized that there's some overlap between the genes that are responsible for both. So this particular trial was a genome-wide association study, meta-analysis. So they took all of the genome-wide association studies they could find that were related specifically to smoking, tobacco smoking, so regular cigarettes. And they also used the genome-wide association studies that were looking for genes associated with schizophrenia. What they did for the patients who were smoking is they broke them into 5 categories, whether they ever or never smoked, the age of smoking onset, so whether it was earlier or a little bit later in life, the number of cigarettes per day, whether or not they developed nicotine dependence, and if they were current or former smokers. So they ran the meta-analysis looking for all of the single nucleotide polymorphisms, all of the gene changes that were associated with these particular factors. They did the same with schizophrenia. They had 128 different loci for the schizophrenia one. And what they found when they compared the two lists was that for some of the genes that seemed to be associated with ever or never smoking, and those with nicotine dependence, were also the genes that were in the polymorphisms that were responsible for the development of schizophrenia. Now, because this was just a meta-analysis, they weren't able to tell directionality. So is it a direct link? And because of this single polymorphism, it causes both things. Does it cause one thing first and then the other? But they do see that there is an association there. Interestingly, they were able to find one particular polymorphism for nicotine dependence was a gene that's responsible for the nicotinic acetylcholine receptor. So that receptor we looked at the very beginning. So it's been associated with the development of schizophrenia, and it also seems to be one of the strongest indicators for the development of nicotine dependence. So it does look like it may play a role in the development of both of these conditions. So maybe there's a genetic component. But also maybe there may be other factors that are going on, and some of the patients are using cigarettes to get nicotine to be able to self-medicate. So there's a couple things they could be self-medicating. For these two, there's a different trial, one in the right-hand column, one in the left-hand column. So we're going to start on the left here first. So this was a study that was done at one outpatient clinic that had 78 patients with schizophrenia. 58 of those patients were smokers and 20 were non-smokers. And what they found when they looked at these patients was that these patients had less Parkinsonian adverse effects. So those seemed to be a little bit better, but they had more akathisia and patients who were smokers had a higher average dose of the antipsychotic medications that they were taking. It also looked like their brief psychiatric rating score, so the number of psychiatric symptoms they had was higher in the smokers versus the non-smokers. So one of the suggestions is potentially some of the patients were using the nicotine. You get a little bit of release of that dopamine. Maybe that can help with some of the movement disorder side effects that they see. There was another study that was done. This was an outpatient survey. There were 300 patients. They had chronic psychiatric disorders. So they did include schizophrenia, schizoaffective disorder, bipolar disorder, and severe major depressive disorder. So a little bit more of a mixed group. And their percentages, so 56% were current smokers, 14% were former smokers, 11% had never smoked at all, 13% were considering quitting, and then 6% were either preparing or actively trying to stop smoking. When they split these into two groups, they looked at those that are currently smoking and those that previously had been smoking. They found that patients who had quit, those that are former smokers, were more likely to be living independently, were less likely to have a comorbid substance use disorder, and they actually had lower ratings on their brief psychiatric rating scale, so the BPRS, so fewer psychiatric symptoms. So it was suggested maybe the smoking is an indicator of patients who aren't doing quite as well. So maybe it's not helping with all of their symptoms, but that might be something that we see in patients who have many more symptoms and maybe aren't working quite as well functionally. Which isn't exactly clear, because if we see nicotine in the nicotine acetylcholine receptor has been associated with memory and learning and executive functioning and processing. So we would expect that if there's more nicotine, we'd see improvement in some of the cognition symptoms and maybe not see that, maybe not see those findings that other survey found. So these are results that were reported in a review that was published by Leonard and colleagues. So they looked at patients who, they looked at all of the studies that were done in cognitive processing for patients with schizophrenia. I picked 3 of them in particular because they look at different aspects. So one of them is auditory sensory processing. So the P50 deficits. So individuals are given 2 sounds and they're done very close together. And for patients who don't have a diagnosis of schizophrenia, that second sound, they monitor brain waves after they give the sound to the patients. The brainwave response to the second sound is inhibited in patients without schizophrenia. Patients who have schizophrenia and their first-degree relatives are unable to inhibit the input of that second sound. So they may not be able to filter out all of the input that's coming in, and that may cause some issues with their ability to process all of that information that's coming into their brain. They found that processing and the ability to inhibit that second sound is actually improved when they were given nicotine when those individuals had smoked. And that was both in patients with schizophrenia and their first-degree relatives. They found a similar finding in the pre-pulse inhibition. So this is actually motor stimulus, and they're given very close together, just like the other one. And usually it's a weak stimulus and then a stronger stimulus. In patients without schizophrenia, that stronger stimulus actually has a weaker response because of the inhibition of most individuals. Those that have schizophrenia and their first-degree relatives don't have that inhibition, and they still have a more robust response to that stronger second signal. They found that this also improved when nicotine was administered, again, in the form of cigarette smoking. So again, not just in auditory areas, but also in motor areas, being able to input, process, and filter some of the stimulus that the patients are exposed to may interfere with their ability to learn, process, or function at a high level. The last cognitive test that they reported on were eye tracking deficits. So there were 2 different ones: smooth pursuit in the anti-saccade responses. So these two, the first is looking at accuracy of tracking a moving object. So having individuals track it and how accurate is the patient in their ability to track something that's moving. So very quickly processing, filtering, and following instructions. The second is actually trying to do something opposite. So looking at higher executive functioning, trying to move in the opposite direction of a they found that the responses for patients with schizophrenia improved and were much closer to individuals without schizophrenia after they had again been administered nicotine. This also was in the form of smoking. So for each of these, it appears some of the cognitive tasks and the tests that we use to show that there's impairment in patients with schizophrenia are all improved when patients are exposed to nicotine, which suggests maybe there's some benefit in cognition for these patients. But we're gonna keep muddying the waters a little bit. There's other evidence that makes that seem a little bit less clear. So if patients are mainly getting the nicotine from their cigarettes, from a public health standpoint, we've not been encouraging smoking. So as the smoking cessation efforts have been launched targeting this population, does that then impact some of these findings? Does that change their cognition? Does that change their psychiatric scales? There are a number of trials. I just looked at this one because it had the data spelled out pretty nicely. So the results of the cessation trials do not demonstrate consistently that there's an exacerbation in psychotic symptoms when patients stop smoking, when they stop getting that extra dose of nicotine. This was one trial that was done. It was a small number of individuals. About 50% of them were able to stop smoking by that 10-week period. They were either on bupropion or on placebo. And what they found, as you can see here, so these are PAN scores, they really didn't see any difference in the psychiatric rating scales across the board for patients who were on bupropion or those that were on placebo. And they didn't see it in patients who had successfully stopped smoking. So they really didn't see the change from removing the nicotine for these patients. They did see a slight improvement in the negative symptoms, although from week 1 with an average of 12 to week 10 an average of 10, I wouldn't say that's clinically significant. But that kind of muddies the waters a little bit as far as how much of a role can nicotine really play in improving things for patients with schizophrenia. Up to this point, we've been talking about nicotine delivered by smoking. There are a large number of reasons why we wouldn't want to encourage smoking. This is my public health slide that's here. So instead of just giving nicotine through cigarette smoking or vaping, which has unclear benefits at this point, although patients are definitely being encouraged to stop smoking by changing to vaping, are we able to target some of the nicotine receptors more specifically? The answer is yes. There's a handful of agents that are under development currently. So this was the most recent trial that was published. It was phase 2 results for an alpha-7 agonist, so something that's going to work right on that nicotinic acetylcholine receptor. And it was targeted specifically to help with cognitive impairment for patients with schizophrenia, as well as patients with Alzheimer's disease. So this was 12-week randomized, double-blind, placebo-controlled, over 300 patients, and they were looking at 2 different doses of the encenicline. So their endpoint was a cog state overall cognition index. So this is a battery of smaller tests that look at different functioning. So processing speed, attention, memory, paired association learning, verbal learning, visual learning. So a composite score of that. So what they found was that there was an improvement in the overall cognitive state score. So if you look on the right-hand side, the cognitive state overall cognition index is the middle graph on the top line. The low dose, so the 0.27, was significantly different from placebo. but it wasn't as robust a response as they had been hoping for. The panel on the right, on the left on the top, is actually the Matrix Consensus Cognitive Battery. So it's a number of tests specifically for patients with schizophrenia to look at their working memory, their processing speed. They did not see a difference in either dose compared to placebo. Because there was a little bit of a signal in the cog state, but not with the matrix battery, they looked at the cognitive impairment domain of the PANS. And what they found with this was that the higher dose of the anacycline had significant improvement compared to placebo. So their thought was maybe there is something here. Interestingly, one of the more robust responses is at the bottom, where they did see an improvement in the negative symptoms of the PANS in patients who were on this agent. So the thought was, well, maybe this could somewhat improve cognition, but could also help with negative symptoms. So for all good news, there often is corresponding bad news. For this particular trial itself, the adverse effects that were more commonly reported than placebo were dizziness, nasopharyngitis, and a rash. There were few patients, I think there were only 6 that had to discontinue because of adverse effects. The other adverse effects that had an incidence of over 4% were headaches, general infections, and gastrointestinal disorders, although none, they had nausea, vomiting, constipation, and diarrhea specifically called out, and none of them were even over 2%. So overall, it looked like it was really well tolerated. So the drug continued into phase 3 trials. At that point, it was halted. It was halted by the FDA due to gastrointestinal issues, although there was no specification, and I did do quite a bit of digging to try to find what those were. It was not released specifically what those gastrointestinal issues are that stop the development of this drug. They were given permission by the FDA to continue development for cognitive, for the treatment of cognitive impairment in patients with schizophrenia. They declined to do so. So they stopped completely the development of this agent. There was one other alpha-7 partial agonist, and that's the bradencycline. So this they were looking at for negative symptoms, cognitive symptoms of schizophrenia, and ADHD. That also was discontinued in its development, and it wasn't very clear why that one was discontinued, but it was right around the same time frame. Interestingly, they just released results of a clinical trial. They're now developing this for the treatment of chronic cough. So maybe there is a signal for some improvement. In some patients, we do see improvement for some of them in negative symptoms and cognitive symptoms, but it's not consistent. And we really don't have information related to just specific nicotine actions itself. So there definitely are some safety considerations for the use of nicotine-specific agents, but there's a bunch that are still under development earlier on. So it's likely we may see an agent in the future that has nicotine-specific actions, but at this time, really, there's not a complete green light that this is a great option for our patients with schizophrenia. With that, I will turn it back over.